Good evening, Dr. Harsha, sir.
Very good evening. Very good evening. You have made that corrections, right?
Yes, sir, I've done the correction.
Hello, hi, good evening. Navneet, have you called Prakash, sir?
Hey, hi, Pratik. No, you want me to call?
Yeah, just call him. I had dropped a message to him, but he has not replied.
Yeah, I'll call back. Pratik, sir is joining.
Okay.
All right.
And Rudra? Rudra has joined? Not yet, no?
Shall I call him?
Yeah, just ask him.
Yeah. I will call him.
Harsha, I'm calling him. It's
Okay,
busy. I'll follow it up.
Okay. Bye.
Hello. Hello. Hi, Dr. Navneet. Can you hear me?
Yeah, you're on.
Perfect.
So I've dropped a message to Kunal Gala, sir, also. So he will also join by the time his lecture is.
Okay.
Pratik, you want me to introduce how is it going to work?
Yes, sir. I don't think Puri sir will be joining us. So
yeah,
I
that's
think,
okay.
Yeah. So you can introduce, and then Navneet can give his talk, and then Rudra, and then Kunal Gala, sir.
Super. That sounds fun. And just tell me, for you, I should introduce your main attachment as HCG.
HCG Kolaba is okay, sir. Yeah.
HCG Kolaba. And Rudra, for you only Balco?
Yeah, Balco is enough, sir.
Okay, super. And Navneet, for you?
Nothing, sir. Just Mangalore is enough.
No, but I have to give you a hospital. You don't operate out of your house, right?
No. I mean, I am not affiliated to any particular hospital, sir. That's
Oh
the
wow.
reason.
Okay, super. Okay, that is awesome. I will do that.
Yes.
And I know Kunal. I know. Okay, super.
Harsha is there. Sir.
Yeah. No, Harsha, but I know. I'll say
Okay.
like the eastern zone of India or something like that. But I thought Prateek will be on chutti.
Yeah, I expected the same, sir.
You know?
I am on chutti, sir.
You are okay. Fantastic. That's well done.
So we'll be starting at 5:30. So we
Yeah.
can so depending on that we can.
And any housekeeping announcements, Prateek, in the sense of would they leave questions on the chat and stuff like that?
Yes, on the
Okay.
chat, and if there are, then we can take it as it comes. Like once
Super.
the lecture is over, and then Navneet
Super.
will be moderating those list of cases, and during that
Yes.
they can discuss it.
Super.
Yeah.
Sounds good.
So I can see very few people have joined. So do you want to wait for 5 minutes, or should we start on time and then see as they come?
I think if Prakash sir is also okay, I think we can wait for 5 to 10 minutes.
Yeah. So Prakash sir is muted. I think. Yeah.
No, I was thinking, what's our deadline to wait?
5 minutes.
Yeah,
5:35.
sure. Yeah, sounds good.
So it's 5:35. I think we'll go ahead.
We start, Pratik?
Yes, sir. We'll go ahead.
Okay. Okay, good evening, everyone. I'm Dr. Prakash Naik from Tata Memorial Hospital. Today on the 10th of June, for an hour and a half, we'll have yet another session from the auspices of the Sarcoma Education Foundation, along with the Indian Musculoskeletal Oncology Society and Bombay Orthopedic Society. And I want to thank Pratik Hegde for getting all this together. So we have a team of surgeons and intervention radiologists from Sarcoma today. We'll deal with some advances that have happened over the last few years. Mind you, a lot of these advances have been in vogue with better evidence being generated for its disseminated use. The first up, we'll have Dr. Rudra Pratap Singh Thakur, who is a consultant at Balco in Raipur. He will update us on navigation in sarcoma surgery, following which we'll have Dr. Navneet Kamath, who's an orthopedic oncologist from Bangalore, who will give us tips and tricks on what Kanyadel technique is and other biological reconstructions, particularly applicable to pediatric sarcoma resections. Following which Dr. Kunal Gala, who's an interventional radiologist at Tata Memorial Hospital, would give us the up-to-date state-of-the-art on minimally invasive interventional radiology procedures that are being used for some benign aggressive tumors and some metastatic tumors where they have a significant impact on patients' quality of life with very minimal intervention. Following which Navneet Kamath would lead on a few cases where there'd be a panel discussion based on the themes of the talks that preceded him. A few housekeeping announcements. Whoever has joined in, we welcome questions. Please post those questions on the chat and they shall be answered on the go. Either a response will be there in the chat or some of these questions will be taken up during the panel discussion. Feel free to email any of the guest speakers even later once the talk is done if you should have any questions. Without further ado, I'd like to now introduce and call upon Dr. Rudra Pratap Singh Thakur to give his talk on navigation in sarcoma surgery and what the evidence on it says. Over to you, Rudra.
Yeah. Thank you, sir. Can you hear me?
Yes, clearly.
Yeah. Can you see my screen as well, sir?
Yes, perfect.
Yeah. So I'll be starting. Hello, everyone. Sorry, I am Dr. Rudra Pratap Singh Thakur. I'm a consultant orthopedic oncologist working in Raipur. And today I will be speaking on the topic of the role of navigation in sarcoma surgeries. So to start quickly with it, just a minute, sir. Yeah. So what is navigation? Actually, we know about the navigation that we do use in our phones while navigating in the traffic. Lots of satellite images were taken, and with the help of a global positioning system, we know our exact location in this map. And with the help of this technology, we navigate to reach a destination in the shortest time, avoiding the places we don't want to go, like in the traffic and everything. Similarly, navigation-assisted surgery, also known as the computer-assisted tumor surgery, is performed the same way. Just like satellite images, we take such CT and MR images. After that, just like global positioning system, we have this machine in which there are cameras, infrared lights. The stereotactic cameras emit light, which are then reflected from the trackers that are on the patient and the instrument. And thereby, the help of it, we know our location of the patient and the instrument intraoperatively. And last thing is, by the help of this, we navigate our instrument in the real time in the patient to guide it, avoiding the structure where we don't want to go and take precise cuts. Okay, so why do we need navigation? So there was a study conducted by Kratiaks et al., in which 4 different surgeons performed unnavigated or without navigation surgeries on the pelvis. And they found out that in only 52% of the cases, they were within 10 mm or 1 centimeter of the surgical margins. That means in 48% of the cases, they were either cutting more or cutting less. So what if you are cutting less? So we have evidence that, for example, in this paper by Ozaki et al. In osteosarcoma of the pelvis, if you are cutting marginally, if you are taking a marginal resection, the rate of the local recurrence goes up to 70%. And if the resection is intralesional, it goes up to 90%. So cutting less is also not acceptable. What if you are cutting more? Then you are compromising the structures that we need not to cut. That compromises the functional outcome. So that there is a fine balance between functional and oncological outcome, which are dictated by margins and how many structures that we save. Here comes the role of navigation, and navigation helps us to balance this. The hardware, the system that we use to perform navigation in our hospital in Tata was Stryker Nav3i system. There are many other systems from Medtronics and stores from Germany which are used. And the software that guides us to take cut to navigate intraoperatively is the OrthoMap 3D. So I'll quickly take you through the steps which are performed in navigations. Some of these steps are performed before surgery outside the OR, and some of these are performed inside OR. The first thing that we need to do in these patients is the acquisition of the images. We have to go get both CT and MR images. CT images because we need CT images are better in depicting the bony anatomy of the patients, and MR images because MR images gives us the correct idea of the extraosseous component of the tumor, its relationship with the surrounding structure, and also about the exact intraosseous extent of the disease. The image should not be in an oblique angles, and the image should have a resolution of 1 mm cuts, and it should cover the region of interest with a margin of 5 mm above and below until the skin surface completely. So this makes our navigation system an image-based navigation system, contrary to an image-less navigation system which is used in arthroplasty, in which we need not to take a patient's CT or MR images, in which the data from a population of patients is used to give the information to the machine, and on the basis of that we perform navigation cuts. The second step is the importing these images. It is quite simple. In this we use either CDs or DVDs or a USB drive or a LAN network to import the images that we have obtained outside into the machine. The third step is image set correlations. So these CT and MR images, which we have acquired and saved inside the system, are then fused with each other to form a common image, which will represent the patient inside the machine, like a virtual patient. This is done by two methods. One is automatic matching, in which the machine software will itself fuse the CT and MR images and form a patient. And if it is unable to do that, we can also do something called as a manual or landmark matching, in which we will point out the machine that these are the common points in CT and MR. For example, this is right ASIS on CT and this is right ASIS on MR. And the basis of this marking, the machine will then fuse the images and form a common image. The fourth step that comes in navigation is planning. Planning is the most important part, and there are lots of small segments to it. I'll explain it one by one. First of all is the planes. Planes are basically the cuts that we are going to take intraoperatively to separate the tumor from the body. An instrument that we are going to use, for example, an osteotome, will be moving through these planes and we'll be taking the cuts through with the help of that. The planes are planned in the transverse, sagittal, and coronal, and can be seen images and can be seen on the three-dimensional structure as well. The other part is segmentation. Segmentation means various systems like tumor, blood vessels, nerve roots, viscera, some of the bones can be highlighted so that they can be easily visualized intraoperatively and we can navigate around them. Apart from this, we have provision of marking the trajectories of the screw. We can measure distance between the 2 points. We can measure the angles, and we can mark some evaluation points, which will be the points where we want or don't want to go. This will be the point of interest. So these are the things that we do in the planning on a case-to-case basis. The fourth step is called as point registration planning. This is also done outside the OT to save the time. These are also called as the fiducial points. These are basically very prominent bony landmarks which we can easily identify intraoperatively. And these marks are pointed or marked on the CT images in the system prior to the surgery. This helps us in registration. So registration is basically fusion of preoperative CT and MR imaging that we have obtained with the actual operative anatomy and making a match between the two. And point registration planning helps in registration intraoperatively. So once the patient is inside the OR and we have obtained adequate exposure of the operative field, the machine is roped in and the camera is positioned on the patient. A tracker is inserted in the bone, avoiding the tumor infiltrated bone, and it should be well fixed and it should be facing the camera. Then the tracker is turned on, and as soon as the tracker is turned on, machine knows where the patient is. But the machine still doesn't know is that where the how the patient is lying. It does know where the patient is, but it doesn't know the orientation of the patient or the bone or anything. Then we begin the process of registration. For that, we turn out the pointer and we validate the pointer to show the machine where the tip of the pointer is. This pointer will be now used for registration of the patient. So as I told, registration is basically fusion of operative anatomy with the pre-op imaging that we have obtained. It is done by two methods. One is point-to-point registration. In the previous step that we mark, the body landmarks that we mark on the CT scan are being pointed out to the machine in the real patient, that these are the bony landmarks like point 1, 2, and 3, and 4. And on the basis of this, patient will extrapolate or kind of imagine how the patient is lying in the real world outside the body. This is registration. And this is further improved by marking some of the surface marks on the surface markings on the surface of the bone. A minimum of 30 marks has to be done to reduce the registration error, which is actually a mismatch between the operative anatomy and the pre-op imaging. And the acceptable limit of a registration is less than 1 mm. After registration, we have to check it with a pointer, which means when you are keeping your pointer at ASIS in the real world, real patient, it should be showing in the ASIS of the same side on the screen of the machine. The next step is calibration of the instruments. The instruments, these are the instruments with the help of which we are going to perform our surgery. It can be an osteotome, it can be a burr, it can be a curette, it can be a diaphragm, etc. So tracker is attached to the instrument. Machine knows where the instrument is. But to tell the machine where the tip of the instrument, we have to validate it with a vector calibration device. After this, machine knows where the patient is lying, how the patient is lying, where your instrument is, where the tip of your instrument is, and where the tumor is, and what are the planes that you want to take. This completes your process of planning and everything. Now the last part is navigation. With the help of this guided instrument, we navigate our way into the bone, taking these planes as guides to take precise cut so that the tumor can be easily separated from the body with adequate margins. So I'll be explaining this with some of the examples that we have obtained in Tata Memorial Hospital. So case 1 is a case of an 18-year-old female patient with living sarcoma of the pelvis and sacrum, which was involving the posterior part of the ilium and also encroaching the sacrum. You can see in this image that the tumor was pretty close to the S1 nerve roots, and there was a small narrow space or gutter of normal tissue in between the roots and the tumor, through which we had to navigate our cuts. So we use navigation guidance to navigate our osteotome through this small passage, and we took precise cuts in the sacrums to save the S1 nerve roots. We performed a type 1 plus type 4 internal hemipalectomy, and in long term, patient was having good functional outcome without any deficit, and she still has no recurrence. Second case is the case of a 30-year-old male patient who was having a paraosteal osteosarcoma of the distal femur on the medial side. The disease was not reaching up to the arterial cartilage, and also it was not having much of a bony involvement. In a low-grade sarcoma like paraosteal osteosarcoma, we can take like close cuts to the tumor, and so we planned multiple cuts in sagittal, coronal, and transverse plane with the aim that we can preserve the articular surface as well as the continuity of the bone on the anterolateral side. Under navigation guidance, we took cuts with the help of osteotome through these planes, and the tumor was separated with the articular surface preserved and also the continuity of the cortex preserved. This tumor was then treated with liquid nitrogen and was used as a size match allograft, and plating was done. This is the functional outcome of the patient. So third case is a case of a 10-year-old male child who was having osteosarcoma of the shaft of the femur. After taking precise cuts, there was still some bone left above the physis, and we were planning to use a custom-made 3D printed plate for the patient, which should not be crossing the physis in order to preserve the growth potential of the patient. But crucial to this was that the cuts should be very precise. In this case, we used navigation to take those precise transfer cuts. And after that, that intercalary dissected segment of the tumor was treated with liquid nitrogen and again used as a size match allograft. You can see in the rightmost image that the bone has grown just below the plate. Fourth case is example of a 64-year-old female patient with a parastral osteosarcoma of the tibia involving the anterior and the lateral cortex. There was no intermediate involvement, and we were planning a hemicortical resection in this. The challenge was that the cut that we were planning in the sagittal plane was exiting posteriorly, and which we were not able to visualize on a clinical basis. So we took the help of navigation. We planned 2 transverse cuts and 1 sagittal cut. And after taking this cut, the hemicortical part of the tibia was separated. And again, we used this bone as a size match allograft after using cryotherapy, and it was put back. So apart from this, if we combine this navigation with CAD/CAM software, since the cuts that we take with navigation are precise, the defect that is left can be reconstructed with a 3D printed implant or allograft. And since the cuts are very precise, the fit of the implant is very good. And also it is reflected in the longevity of the implant that we are going to use. So we'll look at some of the literature that supports our findings that we have done. So the use of navigation actually started in 2004. It has already been used in other surgeries like scopy, spine, and plasty. But the first incidence started in 2004 to be used in tumor surgeries. Wong et al. In their study showed that the achieved bone resection matched the plane margins reduced from 29% to 8.7% in their study, which was also reflected in their incidence of the local recurrences. There were many other studies like from Young et al. Which showed that the clear margins can also be obtained in limbs in diaphyseal tumors. So what are the drawbacks with navigation that we have? It is costly. Every technology is costly in the initial days, but we hope that the cost might come down with the future. Second problem with navigation surgeries is that the system is not portable. It cannot be carried from one institution to another. Third problem is it has increased preoperative planning time, but this preoperative planning time decreases time as you start planning your cases in the navigation. And third thing, it does have a learning curve for the development of surgical skills. So thus, navigation helps us to obtain optimal surgical margins and therefore reduce local recurrence. It does have some reduction of operating time by reducing our exposure. It is beneficial in complex pelvics and sacral resection and resection that are to be done around the articular cartilage. And it allows more accurate fit of a 3D printed implant or allograft. Thank you.
Thank you, Rudra. That was excellent summing up of the current state of navigation in sarcoma surgery. And you said it well. I think overall, the key advantage that we have is when you're unable to access where the tumor ends, where there's a very fine corridor between where the tumor ends and normal bone begins. And 3 situations where you want to save critical structures, which includes bone, or a nerve root, or have a precise fit for your custom implants. Thank you for that overview. I'll allow one question, and Dr. Ashik Bari, who's consultant at the Adyar Institute in Chennai, has a question, and a very pertinent one. And he asks, if you have 2 cuts, you mentioned that the relationship between the patient and your anatomy and the tracker has to remain intact through surgery. If the tracker moves, or if you've taken a cut and the relationship between where you have taken the cut and the tracker is disturbed, then you're unable to navigate further. So he asks, how do you navigate after you take the first cut? And if you have 2 cuts and taking the first cut is going to disturb this relationship, how do you deal with that problem?
So there are a few things that we do to avoid this, sir. First of all, the tracker that we insert is inserted in the involved bone, but it is not inserted in the part of bone that is going to be taken off after the resection. So the tracker remains fixed still after we have taken the first cut. But still there will be some mobility after taking out the cut, and we might towards in the second cut. For that, what we do, we mark our cuts before both the cuts before taking our both the cuts. So we will mark it with a diathermy on the surface of the bone. Okay, there we want to start the cut. But still, if we want to do it, what we'll do that the cut which is more crucial, where we want to be more accurate, this has to be taken first. And the second cut, which is like we can have some margin, is taken on the second part. So this is how we try to avoid that moment that happens while after taking the first cut.
Thank you, Rudra. So if I understood you correctly, what you mean is if I have one cut at the sacrum or the sacroiliac joint and the other cut at the ischium, I'll put the tracker in the pubis so that even if I have taken the sacral cut, the tracker is still attached to the segment of the bone where I want to take the ischial cut. Is that correct?
Yes,
Right.
sir.
And also, as you said, you will use your pointer or diathermy or the saw to make your marking to plan the angle of approach before you've actually committed either cut. So you map both the ischial and the sacral cut before you take either cut. Correct?
Yeah, yes, sir. Correct, sir.
Ashik, hopefully that answers your question. And we'll take more questions as we go along, but in the interest of time, I now like to invite Dr. Navneet Kamath, who's going to proceed with the talk on Kanyadel technique and other biological reconstructions, particularly applicable to pediatric bone sarcomas. And what's it all about and how does it benefit our patients? Over to you, Navneet.
So thank you, sir. Rudra, I think you have to stop screen sharing, or should I start?
Yeah,
Yes.
I have already stopped.
We can still see your screen.
We can still see your screen, yeah.
Perfect.
All right.
So I must tell everyone that Professor Kanyadel's team had visited TMH a while ago, and one of the cases that Navneet had done was so impressive that I think it's published in one of Miguel's papers, if I'm not mistaken, and hopefully Navneet
Yes,
will show you that. Over to you.
Yeah. So is my screen visible, sir?
Yes.
Okay. Great.
You are not visible, your screen is.
Okay. All right, sir. Yeah. Good evening, everyone. Greetings from Mangalore, Karnataka. So I'll be talking about Kanyadel technique per se. I have 10 minutes, so I'll restrict to Kanyadel technique, and I've tried to keep the technique description as basic as possible. Most thing you have to realize, understand that it's a very underappreciated procedure, but it's a wonderful procedure, easily doable, and hopefully by the end of the talk, I think most of us would think of doing this technique in appropriate indications. Yeah, tribute to this surgeon who started this Kanyadel technique and their institute in Spain has more than 40 years of experience in performing this technique. This is basically a controlled type 1 growth plate injury. The Kanyadel technique is nothing but a iatrogenic gradual destruction which causes type 1 epiphysiolysis. The youngest child who underwent this procedure was 3 years and the oldest was 15 years. So the majority of the growth plate in children, majority of the tumors in children are very adjacent to the growth plate, up to 60 to 75% of them. And in selected cases, it is definitely possible to do a safe limb salvage by preserving the epiphysis. So just for the youngsters to understand, this is an intercalary procedure. So when we save adjacent joints above and below, and we remove only the intercalary tumor affected bone with safe margin, it is called as intercalary resection. Intercalary resection can be reconstructed with the tumor bone recycling or allograft without affecting the growth of the particular bone. What about tumors which are very close to the physis? So if we try to do a trans-epiphyseal osteotomy, we will get a safe margin, but at the expense of losing a growth plate. And at the same time, the remaining epiphysis which is retained is too small to provide a good stable fixation. Can we do an osteotomy blindly or through with the C-arm through the growth plate? No, we can risk a positive margin which compromises the oncological principles. Why not get a good margin, do an osteoarticular resection and do an expandable? Again, the issues with expandable processes is the high cost, higher complications and need for multiple procedures. So I would like to show a case and we'll go step by step on how to perform a Kanyadel technique. So this is one of my patient who is a 9-year-old child with osteosarcoma of the distal femur. X-ray wise, plain X-ray does not show the tumor going across the physis. The physis appears to be open. So this is one of the cases where the growth plate is close. The tumor is close to a growth plate, and possibly we would be able to save it. So as we all know, we would go ahead with an MRI next. This is the T1 coronal and T1 sagittal image. Again, the tumor appears to be restricted only to the metaphysis. The tumor is close to the growth plate, but it's not adherent to the growth plate, and there is no evidence of tumor crossing the growth plate in this particular case. But is the MRI reliable enough to predict if the growth plate has been involved? Or in other words, what is the best imaging modality to predict the physeal involvement? This also has been answered by the Spanish group. They have done a study of over 65 cases in the pre-MRI era and post-MRI era, and they have found that the sensitivity of picking up a disease crossing the physis is 100% with MRI and CT. The negative predictive value is 100%. In simple words, if the MRI shows no tumor across the growth plate into the physis, there is no tumor across. So, at pre-operative imaging, the MRI is reliable. A preferred is a T1 coronal and a T1 sagittal image. The reason being, T1 provides a good contrast to compare, to differentiate fat and a tumor. Application of a contrast media does not improve specificity in this particular cases. So yes, the MRI is reliable, and this particular child has a tumor in the metaphysis with the free growth plate. So we'll come back to this picture later. You can see the MRI shown previously matches with the first diagram shown here on the left. So we take him up for surgery. The Canadian technique is done in two phases. The phase one is application of a external fixator. So we use two pins into the epiphysis, one anterior and one posterior. The proximal pins into the diaphysis are placed at least 8 to 10 centimeters away from the tumor whenever possible. The size of the pins recommended are 5 mm or even 6 mm. 4 mm pins are used for extremely small children with small stature. So this is a phase one. This is how the post-operative X-ray looks like. There are two pins in the epiphysis and the two pins in the diaphysis far away from the tumor. So not only distal femur, the same techniques can be used in proximal tibials, in the distal tibials, and even the distal fibula. Okay. What do we do next? We start the distraction. The intraoperative distraction, we do about 4 to 5 turns, which is about 4 to 5 millimeter of distraction, till we get a decent amount of resistance. And post-operatively, the child is allowed to walk with the fixator in situ, and the distraction is continued at about 1 mm per day. The physiolysis is expected around day 7 to day 14 from the application of the fixator, so which is a controlled Salter-Harris type 1 physeal injury. This particular child had sudden onset of pain at day 9, which suggests that there is a possibly physiolysis. As you can see, there is limb lengthening by about 1 to 1.5 centimeters. The X-ray shows a wonderful physiolysis. As you can see, the physis is open on this side without an osteotomy. This procedure, from the time of application of the fixator to actual physiolysis takes about 10 to 15 days. So the question comes to, does this actually delay the systemic chemotherapy? Will we be compromising the oncological outcomes? So the answer to that is here, no, we will not be compromising the outcome. The fixator is actually put when the child is about to finish chemotherapy. And the stage 2 is actually the tumor wide local resection and reconstruction. So there is actually no delay in systemic therapy, and there is no compromising oncological outcomes. Now coming to where exactly does the distraction happen? Does it happen through the growth plate? Does it happen above or below the growth plate? So just to summarize, growth plate can be divided into 4 equal parts. The distraction actually happens through the degenerative zone. As you can see here, this is actually a picture of a lamb physis. The majority of the growth plate is retained on the epiphyseal side. There is a thin layer of degenerative physis, which is across the metaphysis. You can see here, this is the area of distraction. Part of the cartilage along the metaphysis is extremely thin. Majority of the growth plate, even the germinal matrix, germinal layer, is retained on the side of the physis. Okay, so the phase 2 consists of excision of the tumor and reconstruction. This particular, every canadial case, we do a single diaphyseal osteotomy. A metaphyseal osteotomy is not required as the distraction has already occurred. But contrary to what we believe that intraoperatively we would appreciate a gross gap across the physis, this doesn't happen because the perichondrium is thick and perichondrium is intact. So under image intensifier, we have to identify the level of perichondrium and make a cut all across the perichondrium circumferentially with a thin knife, and the specimen is opened up. As you can see in the lower left end, this is the resected specimen. The part of the physis is still covering the tumor. The tumor is not visible, and the majority part of the growth plate is retained on an epiphysis. This is one of the pictures shared in the book of pediatric bone sarcomas. So coming back to how safe is this? Normally we are taught that a full growth plate, full thickness growth plate in pediatric population is equal to 3 centimeter of qualitative margin. But in this case, we have not retained the entire growth plate. The cartilage, whatever retained, is very thin. So are we compromising oncological outcomes? Does this pose a risk of a higher local recurrence? So the Spanish group has the highest number of Canadian technique procedures performed all across the world. They have published this 20 years back. They also have published article this year with about 40 years of experience, and there has not been a single case of epiphyseal recurrence in about 100 plus cases of Canadian technique. So tumor bone is resected, and in this case we had used a liquid nitrogen. We can always do an ECRT. We had also added a vascularized fibula to it, and the fixation, coming to the fixation across the growth plate. So though a majority of the growth plate is retained in the epiphysis, the growth can be compromised if we use a plate for spanning across the physis, or we use an intramedullary nail. So as per the literature published by the Spanish group, they would recommend just minimal KYs. Even in very small children, they have actually just put a slab or a cast, but advised a rigid fixation across the diaphyseal osteotomy site. A similar case done in a proximal tibia osteosarcoma in a 12-year-old boy. Distraction occurred on day 10. The physeal, you can see the specimen here, that the growth plate, part of the growth plate is seen very well on the specimen, and majority of the growth plate is written on the epiphysis. As he was 12 and we wanted a stable fixation, we have used a plate across, and there is definitely no growth because there is a hardware across the growth plate. So the indications are very clear. The tumor should be in the metaphysis. The physis should be grossly open. There should not be transgression of the tumor across the physis on a coronal and sagittal T1 MR images. So on the left hand are the possible indication. What do I mean by relative contraindication? So when the tumor is across the growth plate, has not crossed the growth plate but is abutting all through, there is high possibility that tumor might be microscopically across onto the epiphysis. So that would be a relative contraindication. The secondary relative contraindication would be a pathological fracture at presentation. But again, in osteosarcoma and even sarcoma being most chemosensitive, if the fracture unites post chemotherapy, a Canadian technique is still possible. When the tumor crosses across the growth plate, then yes, you are not supposed to do a Canadian technique. What are the complications observed in the series? They have observed the distraction through an unexpected plane, sometimes through a tumor in about only 2 to 3% of cases, which have been salvaged through a transepiphyseal osteotomy, and the Canadian technique was abandoned. There is no increase in the risk of infection due to external fixator, no delay in chemotherapy in any of the cases. Transepiphyseal osteotomy is not preferred in such cases, even in proximal humerus, because the growth plate is not a flat structure, not a horizontal structure. It is undulated. Hence, attempting the intraepiphyseal osteotomy in such cases could leave tumor behind. And hence, in an open growth plate, even in proximal humerus tumors, a Canadian technique is possible. So the procedure is safe, epiphysis is retained, hence you can get a better chunk of bone for stability, for providing adequate fixation and stability. The joint function is better, and there is definitely potential for uninterrupted growth. The other mechanical advantage of the procedure would be retaining of the trochlea. So the majority of the cases which has been shown in their series are use of allograft and not tumor bone recycling. So if we do a transepiphyseal osteotomy in a distal femur in the child, which is replaced with an allograft, a tibia or a femoral allograft, there would be mismatch at the trochlea, causing impingement at the patellar trochlear junction. And in cases of proximal tibia, performing a canadal technique retains the patellar tendon attachment. Similarly, in a proximal humerus canadal technique, the rotator cuff attachments are preserved. The reason I've underlined a potential for uninterrupted growth. So, though the physis is retained, fixation across the physis, a need of a post-operative radiotherapy can compromise the future of the growth, particular growth. So this book, I think I would recommend everyone here to go through this book if they have not already gone through. This was published in 2009. This was published in 2009. And you can see that there is no mention of any case being done in India at that time. But you can see this article, this year's article, and a couple of us surgeons have already performed this and we have had excellent results. So I would definitely suggest all here to go through this book and probably utilize this very easy and very underappreciated technique in their routine practice. Thank you.
Thank you, Navneet. That was excellent, precise, very communicative, of a very elegant procedure where the science began on animal studies and has been successfully used for 4 decades in humans. We had the good fortune, and Navneet, that was around then, Professor Mikhail Sanhulian had visited us for a couple or 3 weeks, I think, at DMH, where we did the first few epiphyseal distractions here. So to sum up what Navneet said, and correct me, Navneet, if I'm mistaken, so epiphyseal lysis is elegant because it breaks the physis through the degenerative layer. We distract it for about 1 millimeter a day for about 7 to 10 days. At the end of that distraction, you hear, I mean, the patient almost hears a pop. It's associated with intense pain around day 7 or 8. You do it just when the nadir of the prior chemotherapy has ended, and under image intensifier, you can cut it with a knife. And it's a beautiful procedure. At the minimum, you save the joint. If you do get any growth, that's a big bonus. Very difficult to predict if we will get growth or not. Navneet, 2 quick questions to you. One is from our colleague, Dr. Prashant Narahari from Penang in Malaysia. And he asks a very pertinent question. Oftentimes, you know that we see edema in the epiphysis. Pre-chemo MRI, we know it's not disease, it's some edema. Sometimes the kid is in a slab, there is joint effusion or some pain, it may be a sympathetic edema, we don't know. And then all of that disappears at the end of chemo. Are you then safe enough in taking physeal distraction, or does your algorithm change if you found any pre-chemotherapy edema?
Yeah, so this is a very specific question. So yeah, edema is seen most of the osteosarcomas, especially I would say Ewing sarcomas. But yeah, if they respond very well to chemotherapy, and if the post-chemotherapy MRI does not show the tumor grossly abutting the physis, or if it's only focally abutting or quite little away from the physis, yes, canadal technique can be safely performed. But I think Dr. Ashik Berry also has a question on fibular osteotomy in compulsory. Yeah, right. This particular case, I had done a fibular osteotomy, assuming that it would probably interfere with the distraction. But later I did discuss with Professor Mikhail, and he said fibular osteotomy is not a must for any case, and the distraction does happen without fibular osteotomy also, without any issues.
So interesting. So you're saying in none of their cases have they ever done a fibular osteotomy to achieve tibial physeal distraction?
Yeah, so in the entire PDF book, they have not mentioned anywhere about performing a fibular osteotomy. And in person, I have discussed this particular case after performing the osteotomy, said, should I have done or should I have not done? So he said, it's not required. It usually distracts very well without any issues.
Right. But I assume when you did the osteotomy, you kept the periosteum intact? The fibular osteotomy?
Yes, sir. The periosteum was intact. I just opened the periosteum one place and just did a osteotomy with the...
Exactly. Yeah, in which case, even if you did do the osteotomy, I guess the outcome was pretty good.
Yeah, yes.
That is awesome. And last but not the least, how often through their series, I mean, in our experience, for the most of the cases that we've done, we've ended up using at least cross-threaded cancellous screws. Only in a very young child have we relied only on K-wires. What has their experience and your experience been on using? I saw the X-ray you showed. You've just used about 4 K-wires across the physis. Till what age are you comfortable doing that, and beyond what age could you either use cancellous screws with a washer, or just extend the plate beyond biting the bullet and saying, listen, I'm saving the joint, I'm not going to get growth, but I think I need union more than growth. So beyond what age do you make that decision?
Yes, sir. So the femur case was the first one I had done with the congenital technique. And since we are new to it, we are discussed with Professor Mikkel. So he said, put only 2 wires. You don't need more. It will unite since it's a metaphyseal and immobilize the child. So I actually only put 2 smooth K wires, no screws across, only smooth K wires. But I was not very happy with the stability despite of a proximal plate. I felt on little knee flexion, it was opening up anteriorly. So I ended up putting 1 more. It was not stable. I put 1 more, 4, total 4, because for me stability was a priority, and I thought we'll deal up with the growth issues later. With the 4, the wires were holding quite stable, and so I think it was okay. And moreover, it's about minimal fixation at the metaphyseal osteotomy side. So I would not rely on the age per se, but I would rely on the build of the child. If it's a heavy build child, even if it's small, probably I would look at something stable. Again, coming back to what they have used, they have actually used bone staple in a couple of their cases. We don't have experience. I don't have experience per se with bone staple, the Coventry bone staples. Yeah, but probably next time, if you have a heavier child, probably I would think of using a bone staples for better stability than a K-wire.
Thank you, Navneet. And how long did you immobilize them?
So I immobilized them only for about 6 weeks, 2 months.
6 weeks. And you started mobilizing their knee?
Yeah, range of motion, yes. The other child, I had put a plate, so I mobilized the child immediately.
Right. That's an excellent overview, and hopefully we see many more cases and have a longer series to know what their growth outcomes are like. Thank you, Navneet. Without further ado, I wanted to check with Dr. Pratik Hegde if Dr. Kunal has joined, and I couldn't see his.
Yes, sir. Kunal sir is online.
Super. So now I'd like to invite Dr. Kunal Gala, who is Associate Professor in Intervention Radiology at Tata Memorial Hospital, Mumbai. Today, he'll take us through image-guided ablation, cementoplasties for benign aggressive tumors, including both soft and bony, and also some specific metastatic settings where minimally invasive techniques have given us a new tool in our armamentarium for patients who then don't need an admission, are typically able to get in and out of the hospital on the same day with significant pain relief and significant disease control rates. Over to you, Kunal, and thank you for joining us.
Yeah, hi, thank you for the kind introduction. So today's topic is image-guided ablation, be it cryoablation or RF ablation, and along with that cementoplasty in few cases. So am I audible?
Yes, clearly.
Okay. So without wasting much time, I would be describing ablation in these headings: introduction, modalities, mechanism for radiofrequency ablation, cryoablation, indications, few of the examples, review of literature. So coming on to ablation, ablation is predominantly divided in thermal and non-thermal energies. So in thermal, it is either a heat base, that is radiofrequency ablation, it laser ablation for varicose veins, high intensity focused beam ultrasound, and microwave ablation. So the energy spectrum varies. It can be from megahertz to kilohertz. And coming on to cold base ablation, that is a cryoablation, and where we use liquid nitrogen. That is one technique. Another technique is using either argon helium combination of the gases. Coming on to non-thermal energy is irreversible electroporation. So here what we do is we use a high voltage energy into the patient's body, and that's how as high as 3000 voltage of energy is used. And here the tubular structures are not destroyed. So it can be ureter, sciatic nerve, or pancreatic duct. So this is for the non-thermal energy. So another is a chemical ablation with absolute alcohol and acetic acid. So indications for ablation for benign bone tumors, it is for osteoid osteoma, osteoblastoma, chondroblastoma, and giant cell tumors. For malignant lesion, it's predominantly for pain palliation, debulking when we can't cure it, just for pain palliation, and as an adjuvant to osteoplasty or cementoplasty. That's generally used. So, coming on to the principle of RF ablation. So, when we place the electrode into the patient's body, and this in turn is connected to a generator, and this generator is connected to the grounding pad, and that's how the circuit is completed. And when electric current is passed into the patient's body, there is agitation of the ions which are located into the patient's body, and that's how electrical energy is converted to heat energy due to oscillation of ions, and that's how the heat energy is converted. Coming on to cryoablation, principle is basically the cryoablation destroys the tissue by freezing, and that is the ice formation into the patient's body, and this is due to the Joule-Thomson effect, where the change in temperature of the gas that results in compression and expansion of that gas, and that's how the ice ball formation happens. So here the cryogen gas, there's change in temperature, and that's how the ice ball formation happens. And at the center of the ice ball, it is as low as minus 150 degrees Celsius. And as you move out, it becomes to the body temperature. So it would be minimum at the center, and as you move away, it would be to the normal temperature. So mechanism by which cryoablation happens is by four mechanisms. So there is intracellular ice crystallization, then it causes extracellular ice crystallization. So this rapid rapid freezing and thawing destroys the tissue, and it also damages the blood flow to the tumor, and that helps in immunotherapy and cryoablation. So that's all the principle about the RF and cryo, which we commonly use in bone and soft tissues. So for osteoid osteoma, where this is a 21-year-old male, there is a sclerotic rim, and on MRI confirms the finding of osteoid osteoma. Ablation is carried out with the help of RFA, and that's how post-ablation, the pain which was there 7/10 has reduced to 1/10 to 0/10, and that's how it become asymptomatic just with the placement of one needle. When there's osteoid osteoma, which is located in the spine, after ablation, there's no PET avidity which is seen, and the pain also reduces from 8/10 to 0/10. So this is how the RF energy is used to ablate an osteoid osteoma. So coming on to review of literature, which also tells that the primary success is more than 95% in most of the cases. And these are the published papers from India. Now coming on to another disease which we ablate is osteoblastoma. So these are generally located in the spine or along the pedicle of the spine. So this is a patient, 22-year-old young patient who had a neck pain, was on analgesic, and what we see, it's closely located around the pedicle of the spinous process of the C4, and that after ablation, the patient has regression in the pain, and also there's no avidity post ablation. So here, when till the time we did not had our cryo ablation machines, we were still using RF ablation, and it works well with RFA. Coming on to other thing, when we got a cryoablation, so the advantage of cryo is you can see the ice ball formation into the CT scan gantry, and that's the biggest advantage of cryoablation. So you are much more specific as compared to RFA. So this was a 22-year-old male who had a pain in left chest with a pain score of 8/10 and pain inventory score of 26/50. And what we can see is PET avid lesion, and this was osteoblastoma, which was biopsy proven. And then what we did, we put in a cryo probes, and this is how the ice ball formation happens. Actually, the ice ball formation, whenever it goes into the soft tissue, that is how we identify that ice ball is forming within the bone, because it's an osteoid containing matrix. So it's difficult to identify inside the bone, but as soon as it reaches the soft tissue, we can identify the ice ball formation. So this was the pre-procedure. There was PET avidity, which did not have PET avidity post-procedure. Patient had reduction in pain, and that's the hallmark for cryoablation. So coming on to another disease is a chondroblastoma. So coming on to the surgery was preferred a technique before the RFA for chondroblastoma came in. And in surgery, what used to happen, since these are generally growing kids who has this problem, so injury to articular cartilage and open growth plates, which may be there, which leads to growth disturbances, which reduces the range of movements, premature arthritis, and local recurrence with surgery was around 10 to 20%. So the RFA as a modality was taught in, and then since it is minimally invasive, it's daycare procedure. A patient goes home the next day. So RFA was much more being used nowadays for less than 3 centimeter lesions. So this is a 12-year-old kid who had a pain in the knee and was diagnosed to have a chondroblastoma. RFA was done for this kid, and post RFA, there is no PET avidity within the tumor, and the pain was also reduced. And these are a series of other location where we had done a RFA for chondroblastoma, and the humeral, lunate, femur, acetabulum, acromion. So these are the various other places, and this is one of the article which was published last year. And so the complication rate was around 2 out of 26 of the patient, and both of them had bony collapse, and the pain reduction in all those patients was around 92%. So RFA has shown effective, but as I told earlier, the cryo has come in. So here we are now going ahead with cryoablation. So this was a 9-year-old male who had a hip pain, a pain score of 7/10, and it was located in the right hip. And after cryoablation, the pain score reduced to 3/10, and MSTS improved from 20 to 23, and that's how post cryoablation there is no avidity in the lesion. So when do we do ablation in case of giant cell tumors? When after the angioembolization and denosumab forms the predominant thing, but in spite of that, the patient is having pain and the soft tissue is increasing in size. That is the time we do ablation in a few patients, and the pain score reduces from 8 to 1. And here there is good amount of sclerosis which has formed, and the size of the tumor has reduced in size. So coming on to another benign tumor, which is their benign aggressive tumor, which is a fibromatosis, and this was one of the chest wall fibromatosis. And after 3 sessions, we can see there's reduction in size, and after 5 sessions, there is almost near complete reduction in size of the tumor. This is another case who had restricted range of movements in the shoulder girdle, and after 3 sessions, what we see is a reduction in size. However, this has to be used always in combination with either chemotherapy, where they are increasing in size or they are not responding to chemotherapy. Coming on to cryoablation in fibromatosis. So this was a young kid who we can see there is a swelling in the gluteal region, had surgery done for debulking and was on chemotherapy. And in spite of that, there was increasing the size of the fibromatosis, the gluteal component, and sciatic nerve is completely encased into the tumor. And this is how we plan our cryoablation. So this is how we are planning cryoablation, so that when we do cryoablation, we generally plan overlapping ablations, so that we need to cover each and every area of the tumor as much as possible without injuring to the neurovascular bundles. So this is how the ice ball formation actually seen on ultrasound, and on CT scan we see as hypodense structure. So in soft tissue it is seen pretty much well, whereas in bone it's difficult, but whenever it reaches the soft tissue we can easily identify the ice ball, and the maximum size that we can ablate is around 5 centimeters. And on follow-up, what we see, the nerve is the sciatic nerve is preserved, and we can see good amount of necrosis. So this hyperdensity is a necrosis, and this is still a viable periphery. So this is how the size has reduced compared to what it was pre-procedure, and the necrosis has happened. This improves the range of movements in patient who is having restricted range of movements. And when we had done a study, we predominantly did with RFA. So we did around 55 patients with 175 sessions. The pain score in the patients who had increased pain reduced from 4.9 to 2.4%, and decrease in the mean size was around more than 50%, and also increasing the range of movements. So cryoablation is also helpful in case of painful metastasis or a painful primary bone tumors like plasmacytoma. So this was a large tumor which was involving the vertebra. Patient had already received chemotherapy, radiotherapy. However, the pain was not under control, and the re-radiation was not at all possible because already radiation has achieved a certain amount of toxicity. So cryoablation was planned in this patient, and this is how multiple needles are placed into the patient's body, and this is how the ablation is carried out and hyperdensity is happening. So the pain score reduced from 9/10 to 4/10, and patient is off analgesic, however, has occasional pain sometimes with around 70% of necrosis within the mass. So coming on to differences of cryoablation versus a heat-based ablation. So what it achieves? So it achieves maximum control of the procedure, because what we see is ice ball is seen pretty much clearly as opposed to unclear boundaries in the thermal or heat-based ablation. It protects the patient's safety. It reduces the complication and adverse effect. So whenever we can see the ice ball, we need to stop then and there, and in RFA we do not see any ice ball. The pain control is pretty much well with cryoablation, and cryoablation just requires minimal amount of sedation as opposed to heat-based ablation, which requires deep anesthesia. Coming on to few of the pain palliative procedures is a cementoplasty or pain palliation. So cementoplasty is done for either metastatic bone disease or multiple myeloma. This is how we place the needle into the patient's body via the transpedicular approach, and this is how the cement is infused into the vertebral bodies. So percutaneous augmentation or the indications are pretty much clear whenever there is a painful vertebra with extensive osteolysis due to malignant infiltration, either due to multiple myeloma, METs, or lymphoma. For stabilization, and we can use combination therapy, ablation with vertebroplasty whenever there is a soft tissue which is present, so that the cement gets well deposited into the soft tissue and it strengthens the bone. So contraindications are generally bleeding diathesis, infection, retropulsion of the fracture fragments, or vertebral canal compromise. So this the few examples are, this is a case of CA breast where this is the lytic lesion in lytic lesion at L4 vertebral, and this is metastasis, and patient has pain of around 8/10, and this is how, for strengthening and for pain palliation, ablation with vertebroplasty was carried out so that there's good distribution of cement into the vertebral body, and thus a reduction in pain. This is another 27-year-old patient for primary bone tumors, that is plasmacytoma patient, had acetabular lesion, solitary lesion with a pain score of 9/10. Acetabular RFA was performed. This is ablation is performed, and then cement is being injected so that the RFA, what does it do, or a cryoablation? It actually creates a cavity, and in that cavity, the cement is well set in, and this is how strengthening of the bone occurs with the help of cementoplasty. So coming on to take home message, ablative therapy is a minimal invasive and is a curative treatment for benign bone tumors. It also ablation also helps in pain palliation in malignant bone tumors. It helps in combination with osteoplasty for stabilization of vertebra or any part of the body. Any weight-bearing part of the body. Osteoplasty helps in strengthening of the bone and for pain relief. Thank you.
Thank you, Kunal. Again, congratulate you and your team on this excellent work. And the advent of or having a great IR team with you at your beck and call is of infinite value. Today, when we see epiphyseal chondroblastomas in the tibia or in the head of the femur or in the supraacetabular area, which used to be a challenge both for the surgeon and for our patients, today are looked after by our very talented IR team with minimally invasive therapies. And while RFA was in vogue, and as Kunal said, it caused some pain, you needed deep anesthesia. The last few years, cryotherapy has come into vogue, where the peri-procedural pain is very little. You can do it in sedation. You do not need deep anesthesia. And most importantly, as Kunal said, they get very good feedback on the extent of the ablation because they can visualize these ice crystals. Also, it's safe around nerve structures. You can be braver when you're operating around the cord or around major nerves and minimize the secondary toxicity. But the biggest take home for me is their excellent work on fibromatosis. And going forwards, it's going to be a huge series of patients where surgery is fraught, almost impossible. They're on Winblastin MTX or a TKI or any of the other sorafenib or any of the other therapies, where we all know size reduction takes a long while. And in young or old patients who are morbid, on whom pain is not going down, there's a big mass, there's a big contracture. We've had patients with big pelvic fibromatosis that have engulfed the ureter. They have had retention, side effects of hydroureteronephrosis. And the only people who came to our rescue was Kunal and Dr. Nitin Shetty and Dr. Suyash, their IR team, where ablation in many patients has given excellent results where we didn't expect the tumors to shrink. So this is, I think, some cutting edge frontier for fibromatosis. And of course, with metastatic cases and palliation, again, there have been saviors where many patients have avoided the need for surgical procedures with the advent of ablation and cementoplasty. So thank you, Kunal, for that excellent talk. And now we're going to try and make up for some time. I'm again going to invite Dr. Navneet Kamath, who shall quickly use cases in our practice, which highlights the topics that were discussed today, which is navigation, Carniadel, and interventional radiology. Hopefully, we'll be able to finish 2 or 3 where Navneet, in his efficient way, will highlight the key aspects. And of course, apart from all our guest lecturers, Dr. Rudra Pratap Singh and Dr. Kunal Gala, I want to invite Dr. Harsha, who's a consultant orthopedic oncologist and assistant professor at the Tata Memorial Center, Visakhapatnam. He's joined us. I'd also like Dr. Pratik Hegde, who has almost been the leader of the SCF at the back end, who organizes all of this. So we are indebted to him. He's a consultant orthopedic oncologist at the HCG Kolaba Center in Mumbai, apart from other centers. And we shall hopefully be quickly summarizing these. Navneet, over to you.
Thank you, sir. We are short of time, so I will go quickly through at least 2 to 3 cases. We'll start with probably a benign one. We have a 17-year-old male with a pain in the left hip Since 8 months. Dr. Harsha, could you quickly read this, please?
This is a plain radiograph of hip pelvis with both hips. We can see an bone lesions, sclerotic lesion with a mild expansion of the bone in the proximal femur on the right side. And there is an sclerotic exophytic growth arising from the proximal femur on the left side. Most probably it could be some multiple osteochondromatosis disorder.
Yes, okay. So, but yeah, again, we would not treat multiple osteochondromas anyways, because it's impossible to remove all. But he came specifically with the pain in the left hip. Could you make out anything in the left hip as to why is it causing him pain?
Some distraction of the joint inferiorly. If I
Yeah,
see.
I can see that there is asymmetry. There is actually a hip impingement. There is lateral translation of the femoral head, which is actually causing him, and he had absolutely no adduction. So the large mass in the groin was actually causing the hip to subluxate on the lateral side. So, Dr. Rudra, how would you want to proceed along with this? What do you want to do any investigations, or do you want to plan anything surgically?
Yeah. So next step I would like to do will be an contrast MRI of the hip joint involving the whole of the femur. I would like to image it first, and then subsequently, if you want to intervene in any form, the patient is any kind of intervention, we also plan a biopsy after that MRI. A true needle guided biopsy will do.
Okay, all right. I'll just show the MRI. You let me know if you want to do any target any area for a biopsy. If you want me to stop, just let me know and stop the image. The pain is across the hip. There is no progression in the mass, size of the mass. It's static, is 17. So you can see there is a large mass arising from the proximal femur, looks like a sessile osteochondroma all the way involving up to the head of the femur. How do we proceed?
So I think we'll have to target the, obviously.
So this is the image.
The vessels we have shown on the MRI, we have to avoid that. And we'll have to take the biopsy from the cartilaginous cup or the part of the lesion. And I think the approach will be from the lateral side.
No, but are you suspecting a malignancy? The cartilage looks fair enough because it's almost end of the growth session. The cartilage is not very thick or obnoxious or anything suspicious. Would you still suspect malignancy?
No, I am not suspecting a malignancy in this, but since we have to have a histopathological base before proceeding with any kind of intervention, I would like to do a biopsy here.
Prakash sir, your comments please.
Yeah, so a challenging case. So first off, I think most of it looks mature bone. I do not see any heterogeneity or any abnormal cartilage cap. So if you ask me to hedge my bets, I would hedge thinking this is a benign mature osteochondroma that is large and that is causing symptoms. However, to address Rudra's very interesting point, and I think till the cows go home, we can keep debating on this aspect. The challenge that all of us face is to rule out. Here, the doubt is this is likely a benign osteochondroma. But before we want to operate, we want to rule out a sarcoma, right? This particular case, I do not think this has any secondary chondrosarcoma based on the MRI. However, in some cases, if there is a focal cartilaginous abnormality, I would not hesitate in doing a PET CT, identifying the highest SUV area, and then targeting my biopsy based on what that heterogeneous area is, because it will give me the best likelihood of targeting the highest SUV site. And I'm hopeful that if it were done in this case, it's likely going to be a low grade and it's going to be mature osteochondroma. And that's my prediction. Over.
Okay. So yeah, so the clinically and symptoms and history, he had no progression in the mass, and the main symptoms were the hip pain, loss of abduction. So this for me looked like just a large osteochondroma causing mechanical issues, which requires removal. So I did discuss with my radiologist, and he said the cartilage is uniform. There is no thickening, there is no abnormal area. So he suggested that we proceed with the resection for the mechanical issues, and the biopsy may not help because it would be difficult to target any particular cartilage since it's a very broad surface, and there was nothing suspicious to target. So let's assume this is benign, and we want to plan an excision. Considering that the issues here would be a large SL osteochondroma, and you can see the femoral head on the left image, that it is almost flush with the femoral head and neck. So, Dr. Harsha, any plans on how to save the femoral head and remove the large bulky mass in the groin?
Can you show me the X-ray once?
Okay, all right, I'll go back.
And the age of the patient?
17.
17.
Yeah.
So, if it is 17, he is almost nearing
It's
the
skeletal mature. The physes are closed. There is no open physes anywhere.
Yeah. So in this case, we can straight away go ahead with the proximal femur replacement because he is almost nearing the maturity. But one thing I worry is because the acetabulum is also, the acetabulum index is a bit high in this. It's not like a normal acetabulum. So I don't know how the proximal head will sit in the acetabulum if I go for proximal femur resection.
Okay. No, my question is there a possibility that you can just remove the osteochondroma and retain the femoral head? See, this is a benign disease. We are looking at removing only the mechanical block. We are not looking at a wide margins, or we are looking at a sarcoma here. So can we do this? This is what the plan was.
But same like a debulking surgery.
No, I would say probably can we remove the exophytic mass medial to this line, green line, and retain the one on the lateral side. And even in the left image, if we can save the femoral head and the neck and just remove the debulking mass, do you think possible?
Yeah, but how much capsule will you be removing that? Because in the X-ray, if you see, the mouse is almost abutting the capsule also. We go back to the X-ray.
Okay. Sir Prakash, any input?
Unstable hip.
Yeah, so quite challenging. So I go back. There used to be so this goes back to the question, historically we've been taught if there's an osteochondroma, you got to remove it with the perichondral ring to prevent a recurrence, particularly in a young kid. So first we're assuming this is an osteochondroma, and I think it is. Very likely this is just a mature osteochondroma. And then the question is, can we do function saving surgery? To give you a brief insight, there was a long series, I forget the name of the author, that came from a Canadian center on the West Coast, probably the University of British Columbia. The pediatric surgeon there had a long series of sessile osteochondromas. Now, see, the challenge in a pedunculated osteochondroma is easy. You cut the stalk, get it out. The challenge in a sessile osteochondroma with a broad base is where do you cut if you want to save function? You need to cut all of it. You don't even know where the edge begins and where it ends. And they, in a long series, showed that it's okay to remove as much as you need to save function, remove that big space-occupying lesion, not worrying much about recurrence, and the recurrence rates were fairly low. To that extent, during my fellowship at Toronto, the prospective trial that I led for the navigation system was coincidentally the first 20 cases we did were all of these giant osteochondromas that needed a resection, and a few parosteals. Majorly, they were all giant osteochondromas that needed resection, and we resected all of them using navigation. And now you could even use a patient-specific instrumentation or a PSI. I would guess in my hands today, I have not used too many PSIs. I have used navigation. My goal today would be to save the head and the neck, take it away from the metaphysis and the neck, to take the space-occupying lesion out. And as Harsha said, if the capsule has a breach or I need to do an arthrotomy to get access, I'll repair it back. But I'm fairly confident that in this case, the vascularity to the head will be preserved and we'll be able to save the hip. So I would probably just go ahead and resect this using navigation or a PSI.
Okay. So again, the patient was counseled that it probably looks benign. A biopsy would not be possible because the cartilage is uniform. There is no suspicious on imaging or clinically of a malignant transformation. And we did counsel him that it's a benign disease. So the aim of the surgery would be to remove the medial large mass, which is actually blocking. There is a risk of delayed AVN to the head. There is a risk that our saw blade might pass through the femoral head. And in case we might have to do some major reconstructive procedure if that happens. Further, I just want last quick question to Dr. Rudra before we proceed. Would you suggest navigation to remove this? Dr. Rudra?
Can be done. Navigation can be done in this. Yeah, can be done.
All right, perfect. So yeah, we did not have navigation when we were planning this case. So I thought maybe we could use, as Prakash sir mentioned, we could use probably a patient-specific instrumentation. We designed this. We made a jig to be placed anterior on the osteochondroma as well as the adjacent femur at the junction lower part of the osteochondroma. And I was not very comfortable with having a saw because the cut plan was a little curvy linear. So we had a slot, a long linear slot with 2 mm K wire, which would allow a 2 mm K wire. The interesting part of this osteochondroma is the exiting part, where the K wire would exit posterior medially. There was a large osteochondroma. So we had to plan the K wire position in such a way that the exiting also would not harm the posterior part of the femoral head. Dr. Harsha, if you would do this, are you happy with the jig design? Would you have done something different?
Yeah,
It's
jig,
okay.
jig design is okay, but I am thinking about what approach you will take, whether it is a medial or lateral.
Yeah. So
approach.
again, coming back to this imaging, I would take a cut from the anterior to posterior. So I did an anterior approach so that I could place the jig also very comfortably. And you can see the vessels are also anterior. The profunda was actually stretched all across this green line. And it was very difficult to place the jig. So yeah. So jig design, you're okay. Any comments on the jig design? Anyone? Would you want to do anything different, or shall we proceed with this?
Yeah, so I think the anterior approach is a good idea for 2 reasons. One is that typically when you want to go high and want to go down distally beyond 5 centimeters, having the nerve lateral to me helps, so that the first innervation of the rectus and the quads gets saved. If I do a lateral approach and I want to go high and low, there's no way to avoid, and you pull and tug on the nerve supply. So I think it's a great idea to plan a dead anterior approach, medial to the vessels, take the entire neurovascular bundle laterally, and go bang on. The only so probably it's challenging in the PSIs to have a K-wire depth guide, so you could measure it and figure out where you want to stop and then connect it with osteotomes. Otherwise, it looks good design.
Yeah. So exactly what I had planned. We designed this jig. We had a bone model as shown in the picture. Everything looked perfect. But there was one thing which I did not account for, and that was an error with the jig design. As you can see on the left-hand image, this is a CT-based design of the jig. But we have to remember that this is an entire thing is an osteochondroma. There was cartilage on the anterior aspect of the mass too. And hence the jig was not sitting properly intraoperatively. This part of the jig was not sitting. This part on the other hand was on the femur, so it was sitting quite well. That is the reason I had to trim the medialmost part of the jig because it was not sitting well on the cartilage. Once I removed the major part of the jig was sitting perfectly. The femoral artery is here, the femoral nerve is on the lateral side. You can see the branches here. Everything was saved, and did multiple K-wires all across.
But Navneet, why did you not use the MRI to plan the seating? Why did you base it only on the CT?
Yeah, so I thought the CT was easier, and the company in Pune who made this design, they said they do not have softwares for MR based PSI yet. So we did it with the CT. And again, as I said, so I had not anticipated the anterior cartilage cap. So, but fortunately, I could just trim the end of the jig and we could place it perfectly. Precision actually went very fine. There is a small area of osteochondroma at the ischial tuberosity posterior middle, which I had to separately use a nibbler and take it out. But majority of the mass came out en bloc. And you can see here that the hip plus subluxation had resolved.
Yeah.
Post-op, the range of motion was actually better. There was good adduction also. And he did fine, but the gait was not much better because he had multiple large osteochondromas around the knee. So the gait was the same, but his symptoms improved wonderfully.
Dramatically. Kunal, Navneet, I'm going to just interrupt. Kunal, correct me if I'm wrong. Is it possible to just adjust the Hounsfield units, get the cartilage cap component right on the CT image when we submit it to these design engineers? It's possible, right?
Yeah. HU values on the CT scan. Yes, it's possible.
Yeah. So I guess Navneet, the next time maybe we can adjust.
I think that's a good idea, sir. I did not think of it. So I think
you adjust the Hounsfield unit image for cartilage and for bone, That's on the same CT. You can fuse both. So you can clearly see cartilage and bone and help them plan on the cartilage.
Perfect.
So one last question, sir, before moving on to the next case.
Yeah.
Since this is a benign disease, we have already agreed upon that, and we were not worried about the margins or saving any kind of crucial structure.
Yeah.
We have avoided any kind of PSI navigation, just gone in and with the help of just eyeballing it with the help of an osteotomy, we can take and taken the cut.
So,
and since we are already using nibbler, we have nibbled out whatever was there.
yeah. So Rudra, just see this image. The worry was, you can see this axial image is at the level of the green mark here. Can you see this? Sorry. Yeah, you can see that there is no plane between the mass and the femoral neck.
Okay.
The worry was that my saw, though I can eyeball it anteriorly, the saw would exit through the femoral head on the neck posterior medially.
Okay, then avoid it and just use a nibbler there.
Yeah, I was not very sure that, because see, it's a 3D mass and you're doing it, you're identifying on a CM image which is 2D.
Okay, okay.
PSI hardly cost 5,000 and got me a good precision. So
okay.
I was not very confident doing it blind. But yes, if the PSI failed or if I drop it on table, then yes, we have to do it the other way. But nothing of that sort happened and case went fine. So I think it's good.
Okay.
Second case number 230, I'll just quickly go through it. A 38-year-old male, he's an engineering college professor, had a pathological fracture of neck of femur. Unfortunately, did not underwent any MRI or biopsy. They did a neck of femur fixation. Intraoperatively, they realized there is a defect. They did a curettage, put a bone grafting in 2011. The final HPR came as chondrosarcoma, grade 1 chondrosarcoma. So he underwent resection and megaprocessing in the same contaminated field within a week of the primary procedure. Had a massive recurrence in the pelvis. In 2017, underwent hindquarter amputation. So for all the youngsters here, when I meant a hindquarter amputation, it's removal of the entire limb along with the pelvis. So the hindquarter amputation was done through the sacral ala on the right side. He had some unusual bowel disturbances. So he got an MRI on his own, found a local recurrence in the sacrum. Biopsy proven chondrosarcoma grade 3. He's non-metastatic still. I would just like to put up the images. Prakash sir, if you just comment on the images, please. I'll go to one more coronal images in the next slide.
Yeah, so I presume this is an FFE or a contrast PD-SAT image that shows but I'm just surprised, I see a lot of that cystic element that's going in the canal, but I don't see a lot of surrounding bone edema. I would have expected bone edema to be touching the midline. So that's good news. I can see the lumbosacral root is probably bang on the surface. I'm not quite sure if it's involved or not. The L5-S1 looks okay. I'm not sure.
Yes, so this is the S1 foramina.
Yeah,
so this,
L5-S1 looks
S1
okay.
Foramina, we have the disease.
Yeah,
disease is not crossing the midline.
Yeah.
And there is disease in the lamina.
In the lamina.
Lamina on the same side.
Yeah.
There is
so
no disease in the canal. Yes, sir.
You're almost looking at something like a hemisacrum.
Yeah, like a hemisacrum, but luckily there was no disease in the S1. The S1 looks free on these images, not even edema on the imaging. Dr. Rudra, your approach, surgical definitive radiotherapy.
So the radiotherapy is not going to have a role here, but since chondrosarcoma treated with surgical resection, we'll like to try a surgical resection if feasible. But here I think the sacral nerve root, the S2 nerve root is pretty close, and I think I have to look at the imaging again, but it looks involved. So we might need to sacrifice it, but still the resection is possible by doing a hemisacrectomy kind of approach.
Hemisacrectomy. Would you want to do it? See, this is not crossing the midline. Are you comfortable with doing a hemisacrectomy under CM guidance? Would you want navigation? Would you use a PSI here?
So either a PSI or a navigation will be required in this case to take precise cuts, because we have used navigation in sacral resection in order to save the roots, and some kind of like oblique fashion cuts are required along the roots to save them. So I think it will be better to be done with a PSI or a navigation to save these roots if possible.
PSI or navigation. Okay, Dr. Harsha, PSI or navigation?
Navigation.
Navigation. Prakash, please.
So can you get me back to the actual image? Because I was just trying to figure out, let's say the vast majority of us who will not have navigation, I was just considering if there's a way out. So see, you're not too keen on saving the lumbosacral root here.
Yes.
Right?
So he
Because
doesn't have a limb on the
Exactly.
affected side.
Right.
So there is no
Right.
point.
Even
Exactly.
even if you don't have the limb, that we have to preserve bowel and bladder function. No, even if you
No.
damage, if there is a possibility to save sacral plexus, we should always save it.
No. See,
No.
S2
So
we cannot
S2,
save.
I think you can't save.
So can't save.
Can't save. It's in disease. The only question here is 5S1, which is not of value because there's no limb. And I was just considering, let's say I don't have navigation, I would not have hesitated opening the sacral canal, identifying the foramina, ligating the roots, identifying the midline that ways, and resecting out the sacrum. Yes, of course, if I have navigation, it will make my life much easier because there'll be less guesswork. And for a fact, when there is a redo, you will err no matter how well prepared you are. So if I have navigation, great, I'm going to use it. I'm not so sure. PSI will probably be equally efficacious here, but I'm not sure that, let's say, if I didn't have navigation or PSI, would I not do the surgery? I'd say no, I'd still go ahead and do it. If I have either or, sure, I'm going to use that.
Okay. So, I was not worried about sacral roots. I was worried about how to go and remove the tumor without affecting the opposite side of the sacrum and without affecting the lumbosacral continuity. So this is just for the youngsters to know this. This is the L5S1 disc, just whatever I've marked. This is the tumor. This is the S1 foramen. So I would not be hesitant to sacrifice the S1 roots and rest of the sacral roots on the affected side. The worry was not to do this. So this would disrupt the lumbosacral continuity and making the patient bedbound. This would be ideal.
Navneet?
Yeah, hello?
Navneet, hi, Prashant here.
Yeah, Prashant.
I was just wondering, what is the current bowel and urinary status for this patient?
No, it's
Because I think that is important.
intact.
That is important. Yeah. So if it's intact, I agree that you should try to preserve the nerve roots. But then again, if you do a hemistectomy here, the chances of having a urinary or bowel incontinence, I think it's not that high.
Yes, true.
You're entirely preserving the other side.
True, very true.
Right.
Yeah. So this is what we would probably have done if we had not used a navigation or a PSI. Doing this without navigation or PSI will likely be disastrous, but this would be very good if we are able to do this. The aim of this planned cut was to save the lumbo L5S1 continuity and probably retain as much of sacrum on the opposite side.
Very honestly though, Navneet, once you identify the sacral S1 foramina from the back,
yes, sir.
Right, it should not be very difficult to identify the sacral alar margins that you need. I'm presuming you'll take the entire flap down. You'll have good enough access in the front because there's an amputation. And you will probably take open the sacral. I'm thinking of if I were to not use, like Prashant said, the odds of me causing a big damage here, like in an internal hemi, are very low. I don't care about saving L5, S1, which means I can open the S1 route. The S2, 3, 4 are definitely going to go because of disease. I open the midline, I identify the midline. My bigger worry here is just for my osteotome to not exit blindly in the front, in that redo sacral plexus area, right? That's like my key goal here.
Sir.
Over.
So would you go through a posterior approach alone? Would you do a combined anterior and posterior, or would you go lateral?
So that's
there's no bone on the lateral side.
Yeah, so that's a good point. So see, the point is posterior alone should be okay here, but I would ensure that I have some access laterally in the parasacral gutter, right? If I have no navigation, because the challenge is, even if I do have navigation, if I have a presacral vein that opens up and I need control, I need some access in the parasacral gutter to control it. So, but the posterior approach is going to give me that. So regardless of what modality I use, I'll be prepared to get vascular control when I need it.
Okay. So we did think of a lateral approach first. I had done this with a surgical oncologist because the lateral approach in this patient was an issue because he had no muscle on that side. You can see on the MRI too. It is just skin, subcutaneous fat, and directly the bowel was there. So
what do you mean by lateral approach here? You can
no, I did not do a lateral approach. We did the combined anterior and posterior approach.
No, but what was the lateral approach even on paper? I'm unclear. So could you mark with an arrow?
The lateral approach, reason being, he did not have a pelvis on one side. Could we have made him take him lateral and access the sacrum from front and back both?
What incision?
No, just a lateral, just a skin incision here, just parasacral incision, and probably access the sacrum from front and back.
But he would already have a prior incision, right?
No, sir. It was a curvy linear incision because the gluteus flap was taken earlier.
Okay.
So there was no linear scar across.
So you were planning a new incision?
Yeah, I was planning a new incision.
Okay.
But considering that he had no muscle on that side and the bowel was just below the subcutaneous fat, we decided to do a combined anterior posterior approach. Also considering the mid-sacral vein. So we cleared anteriorly, we ligated the mid-sacral vein from the front. We use a navigation here. I was not very comfortable with the PSI, so I thought probably we should try navigation here. The procedure went quite well without any issues introp. And since we could not do a laminectomy on the affected side, we had to do a laminectomy on the opposite side, identify S1 to S4. And from the opposite side, we ligated it and used a navigation to perform the cut. Specimen came out very well. The final histopath was a grade 3 chondrosarcoma. The margins were 3 mm and beyond. So would you do a stabilization of this? Would you plan for any stabilization?
But interesting. I know what Prashant and Pratik and Rudra and Harsha think, but was there a way to avoid doing the laminectomy since you were using navigation? Because that's the usual benefit, right? Where you open just the ipsilateral posterior foramina.
Yes, sir.
Don't dissect off the cauda or the phylum terminal, sir, and cut through the front. So you're saying you opened the opposite lamina just to be safe, so that you've retracted the phylum.
Yeah. So the reason we did the laminectomy on the opposite side was I did not want to pull on the cauda when I pull the nerve roots, sacral nerve roots of the affected side.
Fair enough.
So I wanted to open the sacral canal, ligate and cut the roots so that there is no traction on the cord. And the reason being the laminectomy was very easy and I didn't want to injure the roots on the unaffected side.
But did you at any point think that, I'm actually confident enough of going ahead even without a navigation? Or what point did you feel, no, I still need navigation? What was that reason?
No, the navigation was planned pre-op because again, the reasons being not to injure the sacral roots on the unaffected side.
You may have planned it pre-op. Sorry, I may not be asking my question correctly. What I mean is you're intra-op, you opened the canal, you've ligated the roots, you know your direction.
Sir.
What was the uncertainty at that point where you felt navigation is definitely going to add value?
No, because I was not at all confident doing it blindside, despite of doing the laminectomy and ligating the nerve roots. No.
Fair enough.
Because we had very little margin of error above the S1 foramen. So I wanted to take a curved cut just above the S1 foramen. So I thought.
Now remind me, this is a chondrosarcoma, right?
It's a chondrosarcoma.
So would you have wanted a bigger margin superiorly? How much did you plan on the MR? Because to me, this green, the gap between the green and the red line at the edge of the S1 does it seem close, or maybe I'm thinking it's close?
It is close, sir. It is close, but as you can see, even in the earlier imaging, there is no edema above this one. So this is the S1 foramen. There is absolutely no edema above.
So I want the left image, right? The left image you're showing.
The right image. The right image.
No, but if you see the left one, it is showing some.
Yeah, no. That is S2. No? That is S2.
Okay.
This is the S1 foramen, sir. It's an oblique.
Fair enough.
So we got an MRI done in the plane of the sacrum so that we could see all the sacral vertebrae in one image.
Great. I think it's helpful to think of this case like you were doing an internal hemi, and then it adds value.
Yes, sir.
I think Prashant's got a question. Was it Prashant? I don't know.
Yeah. So I was just wondering, probably Prakash, you could add on as well. So Navneet, what is the advantage of doing this curve cut versus, I agree that you would have saved a little bit bone up there and down there.
Yeah.
But, in contrast, without navigation, you would have done a hemisacrectomy.
Easily.
I don't see the benefit of retaining that small amount of bone.
Yeah, you mean the lower curve?
Yeah, Parker.
No,
Yeah,
what I mean is it with navigation, you would have preserved a little bit of bone up there and down here. But if you did a classical...
There was no aim to preserve the lower one. The curve was mainly for the upper one. That's all.
But I agree with you.
But yeah, there's no benefit of keeping that. You see, I mean, classical hemisacral would have given the same outcome. That's my point.
Classical hemi, you mean vertically through S1?
Yeah. Vertically. I just take it out from S1 in L5.
Yeah.
Okay, no. See, that's what the worry here was. If I go midline through the sacrum, considering that he does not have an opposite limb, I was worried whether it would cause instability at L5 and S1. You have a broad L5 vertebra and a very half-cut S1 vertebra. So I was worried that would be some mechanical issues, and we could save it safely here. So we did a curve cut and tried to save the L5 S1 continuity intact here.
Okay, so, I got your point. Point.
So I agree with that point that Prashant, that Navneet made, that if I can get a safe margin and I can save the L5S1 articulation, I would, because it just avoids the need for any stabilization, and that would add value. And I think that's precisely the reason why you ended up doing what you did.
So he's actually, this was the last image at 8 months follow-up. He got the imaging on his own. I did not actually get a CT. He's actually quite okay. It's been 1.5 years. He's on telephonic follow-up only. He's not.
He read your mind, Navneet. He read your mind.
Navneet, we have crossed the time. So if you have one case for Kunal sir, if there's any discussion for an IR case, then we can have that and end this.
We'll finish it off. Okay, so we have a 30, but this is courtesy of Dr. Vishnu Ramanujan, who's a consultant orthopedic oncosurgeon at Apollo Proton Center, Chennai. I did not have a sacral case here. So we have a 13-year-old male with pain in the buttocks since 2 months. He had a urinary retention since 5 days. Sorry for the image. These were the only images available. This was in 2016, if I'm not wrong. Sir, would you want to take this, or shall I proceed to the MRI, and would you want to open?
I think there is a lot of gas shadow if the lesion is in sacrum.
Sure.
I can't see anything else.
I'll go to the MRI, sir. Yeah. So I'll skip to the diagnosis here. This is a biopsy, CT-guided biopsy proven giant cell tumor. He's 13-year-old and he's 55 kgs. He has urinary retention, acute onset for the last 5 days. Hello?
Yeah, I can hear you.
So, do you think what do you think could be done from your side for this? Just one quick question to Prakash sir. So, would you offer a surgery here, or would you treat this as an unresectable giant cell tumor?
For giant cell tumor?
Yes, sir.
I wouldn't operate. No.
No operate.
I wouldn't operate.
Okay, and one more question. He has urinary retention. So, would you do an angioembolization pre-op and do a decompression here?
No, so I wouldn't, because in a lot of our cases where we've embolized and we've given denosumab, the early loss of the urinary function has regained. In patients who come with many weeks or months of deficit, recovery has happened, but it has not been complete. For instance, they have some disturbances with their both urine and bowel continence. It's not as totally incontinent like they were at presentation, but the recovery is not complete. So quick answer is I would not decompress. I would just give denosumab, embolize, and let the neurology recover, because honestly, I think I'll do more harm when I decompress, because there'll be a lot of blood, tumor. It's very hard to know where the nerve roots lie. You handle any which ways inflamed nerve roots. I personally do not think I'm going to add any benefit. So I will personally not decompress.
Okay, all right, sir.
So lesion is above S2.
Yes, sir.
Yeah, so surgery has obviously it would be more worsened, as Dr. Prakash also already said.
So, would you, considering that, what would you want to do next, sir? We would probably send this to you saying it's an unresectable giant cell tumor.
Yeah, so angioembolization definitely holds true, and since along with denosumab, obviously, so we have started denosumab at 0, 7 days, and then 14 days, and then we do angioembolization interim. and then you do angioembolization combination every 6 weekly with denosumab.
Okay, all right, sir. So is there any way you decide that I would do an angioembolization first and give denosumab later, or would you do the other way around?
So initially, when we had before the advent of denosumab, we were just doing angioembolization. But with denosumab, what we have seen is there's good amount of ossification, calcification, which happens along with angioembolization, which reduces the bulk of the tumor. So that was a prior to denosumab era, maybe 2012, before 2014, and then we were doing more or less combination of therapy. I think Dr. Prakash would agree on that.
So here you would still proceed with the angioembolization first?
No. First denosumab combination and then give angioembolization.
So how would you delay your angioembolization? How, like, if he's come to you today with this image and we have started him denosumab today, when would you want to do the angioembolization?
So there is no fixed protocol, at least at TMAT. We are doing in between, like after 3 weeks. But since there is acute retention of urine, maybe angioembolization first would help in this case.
Okay, all right, sir. A point taken. So you would proceed with the denosumab and serial angioembolization once every 6 weeks, sir?
Yeah, so we do till the enhancement or the blush is still there, and till the time we can angioembolize and we can go as distally as possible. And this angioembolization, as opposed to preoperative angioembolization, differs that we use a permanent embolic agent as compared to preoperatively. Yeah.
The permanent in the sense, sir?
A permanent means PVA particles, so those are semi-temporary, and those would occlude the vessels.
Okay, all right, sir. Sir, quick question to Prakash, sir. Would you prefer a ZOL, considering these are massive giant cell tumors, you treat them long term like an unresectable? Your take on denosumab versus zoledronic acid in general and for this case?
So in general, I'll tell you, the first thing I think of when these patients present is symptom relief. They are in a lot of pain, and our experience clearly shows fantastic pain relief with denosumab just after the first or the second dose. In fact, a lot of times post-embolization, when it causes a lot of necrosis and inflammation, for the first 72 hours, the pain scores really shoot up. And they need a lot of pain control when embolization occurs for these big tumors. So I, without hesitation today, I understand that zoledronic is immediately sidal to GCT and denosumab is not, but I think the reliability, consistency, immediacy of response when it comes to pain relief, I'm not talking of tumor shrinkage, that I'm not expecting with either, but pain relief, immediacy, reliability, efficacy, I will not hesitate. I will use denosumab. I will give it as soon as I can. The trouble we have had in the clinic is when we send them to the dental OPD, it's a long process for them to come back. They get an extraction done. The dentists tell us, well, you need to wait 6 weeks. We negotiate with them. We tell them, listen, if it's too urgent only, then do it, else not. Else we just consent the patients that at 4 weeks, you are in need. The risk of ONJ is small, but it's there. You will definitely get some benefit. Now, we negotiate, we start as soon as we can. And they get great relief when we do 07-14-28. Our IR team is a busy unit. We send them as soon as we can for an appointment, the earliest appointment they can, they embolize it. There's no fixed time between when they have received the dose and when they get embolization. I think it's safe to say that you start denosumab, let both of them act, and get the best of both worlds. Over.
Right, sir. So just to summarize, this is an unresectable giant cell tumor. When we say unresectable giant cell tumor, need not mean surgically unresectable. It just means that even if it's surgically resectable, it is quite morbid, considering that the disease is benign. So we would treat such cases in the spine, in the anywhere in the axial skeleton, where it would cause it would be very morbid due to surgery. Treat with serial angioembolization and denosumab. Kunal sir, quick question. Dr. Vishnu actually has one more patient on angioembolization and denosumab. She's a lady, 28-year-old. She wants to have pregnancy. She wants to get pregnant in the future. So what would be your management? Can we do anything without a CT guidance? Is there any other management? Because she would require angioembolization and denosumab, both grossly teratogenic. So
Yeah.
it's a tough case, I understand, but any opinion on that?
So predominantly, so she's pregnant or she's about?
No, she's not pregnant. She's 28, recently married. She wants to have kids in the future.
Okay, I think denosumab is contraindicated.
Yes.
Yeah, hello.
Yes, yes, sir.
Yeah, so denosumab I think has a teratogenic effect.
Yes,
so
sir.
that's why it can't be given. Angioembolization maybe we can do, and then she can plan accordingly if that is growing in size. But if it's stable, it's uneventful, maybe then we can wait and watch.
Okay, sir. So the issue with the CT angio, when we do an angioembolization, if she's okay now, she gets pregnant and then she develops symptoms. What do we do next? What do we offer? Considering this is a benign disease,
I think Navneet, I think we were sought that confusion. I think we'd strongly advise her to not conceive while she's on therapy.
Yes.
So if she ends up conceiving despite advice, we'll cross that bridge at that time.
Yes.
But I think clearly for a lot of our patients who have such a large sacral giant cell tumor and we've discovered they are pregnant, we counsel them that if they are young and if it's not a precious child, they may have no option but to terminate the pregnancy.
True.
Continue therapy, have at least a 2-year progression-free interval when they can conceive. Okay. So I think it's impossible if she's pregnant to expect Kunal and team to safely do embolization and give denosumab. I think that's not going to happen.
Yeah, I perfectly agree with you.
Pratik, I'll stop this, but last question to Kunal, sir. Sir, that's what. Since you in your talk again, you were demonstrating on radiofrequency ablation for benign bone tumors like osteoblastoma and chondroblastoma. Is there a role of RFA for giant cell tumors which are less than 3 centimeters?
So for less than 3, I think denosumab.
Giant cell tumors, RFA.
Yeah. So so you want less than 3 centimeters, right?
Yes.
So till now, there's no much evidence because giant cells tumor are already a very rare disease to begin with. So there's no much data or evidence for those. But we consider any form of ablation only when angioembolization and denosumab does not work.
No, I meant, for example, if you have a proximal humerus chondroblastoma, you would definitely advise a radiofrequency ablation considering the size limitations. For a giant cell tumor, if it's within the size, just like a chondroblastoma, because I have a case today. She's
Navneet, we have crossed much beyond the time limit, and the questions that you're now discussing are way beyond the purview of the audience.
Yeah, all right.
So maybe you can drop a text or an email to Kunal Gala sir and continue your discussion there. Yeah.
We'll stop here.
Yeah.
You've got the orders, Navneet.
Pardon, sir?
You've got the orders.
Yeah. Whatever Pratik says, sir.
Yeah, because I think you've driven away a few of the delegates with your quick questions, and now we don't have much participants for the quiz, but that is the last part of the session that is coming up. Somnath ji, if you're ready, we'll have the quiz, the Kahoot quiz now.
Yes.
So this is a quiz that part of the session that we have for the delegates, a fun part of it, so that we can just interact a bit with them. As you know, we require the app, the Kahoot app, or we can attend online also through the Kahoot website. We'll first show you the demo quiz, and then we'll start the main quiz of this session. A few of you might know that in the last session, we couldn't have the quiz due to technical issues. So a few of the questions are from the last session, that is the metastatic bone lesions, and a few questions from this particular session that we are having. So Somnath ji, when you're ready, we'll start with the practice quiz and request the delegates who are left behind to participate. I can see 18 of them, so at least half of them can participate, and we can have a quiz for this. This is the demo quiz that is being loaded. So you can open up the app and join in with this game pin, that is 8929854. This pin is for the demo quiz, and the main quiz will be after this. requesting the delegates to join with the demo quiz pin, that is 8929854. As I said, there are at least 17 participants left behind, so maybe we can wait till 8 or 9 of them join. We can see how to participate in this and then play the main final quiz for the session after this. We have Dr. Harsha who will be there with us for the quiz. Okay, I can see 7 people have joined. Somnath, you can start with the demo quiz. And we go ahead with the demo quiz. This is a practice quiz before the main quiz starts, just to see how the quiz plays out. So the first question of the demo quiz is, who is the Prime Minister of India? Is it red, Amit Shah? Is it blue, Draupadi Murmu? Is it yellow, Narendra Modi? Or is it green, Rajnath Singh? And we have got the answers in. As you all know, yellow, Narendra Modi is the answer. Now we have the next question of the demo quiz. Which of the following is the national capital of India? Is it red, Mumbai? Is it blue, Kolkata? Is it yellow, New Delhi? Or is it green, Bangalore? And the correct answer, yellow, New Delhi. So that concludes the 2 demo quiz. Hopefully the delegates now know how to play the quiz, and we can have the main quiz starting.
I think you should explain the time frame for that. Most of them don't know, maybe.
Yeah. So we have around 30 seconds to answer each question. Since this was the demo quiz, it was played out pretty fast. The faster you answer, the more points you get. So the criteria is to be quick and to be correct. So if everyone is ready, we'll start with the quiz for this particular session. We'll soon have the game pin for this particular session. So kindly enter this game pin in the Kahoot app. 5217786. I can see 17 participants left, so maybe we can wait till 8 or 9 of them join in. There is a prize money also, and that is for the first 3 places. This is decided by the algorithm based on how fast and how quick and how correct you are. So kindly make sure your name is clear in the box. I can see 9 people have joined. We'll just wait for 1 more minute before starting with the main quiz. And thank you, Prakash sir, for moderating this session. Thank you. So Harsha, if you are ready, we go ahead. We start.
Yes.
We have, I think, 10 people have joined in.
Yeah.
11 has joined in. So Somnaji, we can go ahead with the quiz. Yeah. So starting with the quiz, the Kahoot quiz for this particular session. Remember to be quick and to be correct. So the first question of today's quiz: if a female of age greater than 40 years presents with a solitary lytic lesion, which of the following blood test does not help much? Is it red, serum electrophoresis? Is it blue, CA125? Is it yellow, PSA? Or is it green, CEA? Serum electrophoresis, CA125, PSA, or carcinoembryonic antigen. One of this does not help in this particular case. The correct answer, as majority of you have guessed, is PSA, that is prostate specific antigen. Dr. Harsha, if you could explain that part, please.
Yeah, any lytic lesion above 40 years of age, we the first diagnosis, suspicion of diagnosis will be metastasis or myeloma. So we first evaluate with the basic investigations like myeloma profile, like serum immunoelectrophoresis, and some tumor markers like if they are male, it is a posted specific antigen and CEA and CA 19.9. If they are females, we will exclude that PSA and we include CA 125. In this present scenario, as it is female patient, so PSA is not of any value in this case for evaluation.
Okay, thank you for that explanation. So moving on to the next question. Great. Category scoring system for prognosis of skeletal metastasis includes which of the following? Is it red, previous surgery? Is it blue, previous chemotherapy? Is it yellow, previous radiation therapy? Or is it green, all of the above? Category scoring system for prognosis of skeletal metastasis includes which of the following? Majority have answered all of the above, but the correct answer is previous chemotherapy. Dr. Harsha, if you could explain that point, please.
Pratik, 1 minute. There is some problem with the net. Can you please proceed with this? I will join within 1 minute.
Okay, sure. So category scoring system is a series of questions and points regarding which we have total up and then we get a score beyond which it means a good prognosis, and if it's less, it's poor prognosis. That has one point which is for previous chemotherapy and it doesn't include surgery or radiation therapy, and that is why that is the answer in this particular question. So moving on to the next, we'll skip the scoreboard and we'll go on to the third question. This is an image question, so you please be aware. Total score as per Mirrell's criteria for this. Yes.
I am.
Yeah. Total score as per Mirrell's criteria for this lesion is it red 4? Is it blue 6? Is it yellow 9? Or is it green 12? You can see a lesion in the arm, and majority have answered it as 7, but the correct answer is 9. Harsha, if you're there and if you can explain that point, please.
This criteria is used.
Somnathji, if you can show that image.
Whether there is an
show media.
Whether to proceed for a prophylactic fixation in an metastatic lesion. It has 4 components actually, based on the site, whether it is an upper limb, lower limb, or peritrochanteric region. Accordingly, 1, 2, 3. And the amount of pain, mild, moderate, and severe, accordingly 1, 2, 3. And the amount of bone, less than 1/3, 1/3 to 2/3, and greater than 2/3, accordingly 1, 2, 3. And it is a lytic, mixed, or blastic, mixed, or lytic, accordingly 1, 2, 3. So here the lesion is in the upper limb location, so the score allocated will be 1 point, and the pain is moderate, so it will be 2 points, coming to 3. And based on the size of the lesion, it is involving more than 2/3 of the bone, so it will be 3 points. And the lesion is lytic lesion, so it is 3 points. So total counting up to 9.
Yes.
So if it is greater than 7 score, then we will suggest for a prophylactic fixation of the lesion.
Fixation. Yes. Thanks a lot for that explanation. Moving on to the next question. Prophylactic surgery is not indicated for which of the following options according to Harrington's criteria? Is it red, lesion in proximal femur greater than 2.5 centimeter? Is it blue, avulsion of greater trochanter? Is it yellow, femoral lesion with greater than 50% of the circumferential cortical bone destruction? Or is it green, progressive pain despite adequate radiotherapy? Prophylactic surgery is not indicated in which of the following options? Lesion in proximal femur greater than 2.5, avulsion of greater trochanter, and the correct answer is avulsion of greater trochanter. But we have a mix of answers, so we would like Dr. Harsha to clarify the point.
This is also a similar criteria like Mirrell's, but mostly we will use Harrington criteria for the proximal femur. So he describes that if the lesion is greater than 2.5, or if the lesion in the proximal femur is greater than involving 50% of the circumferential cortical bone, or if there is a progressive pain despite we treating with local radiotherapy, or there is an avulsion of lesser trochanter, which is more prone to pathological fracture. These are the criteria to fix that bone. It is not the avulsion of greater trochanter, it is the avulsion of lesser trochanter.
Yes, yes. Thank you for that point, Dr. Harsha. Moving on to the next, we'll skip the scoreboard again and we'll have the fifth question. Anneking divided regions of pelvic girdle into 4 zones. Location of the lesion in which of these is at the greatest risk of mechanical failure? Is it zone 1? Is it zone 2? Is it zone 3? Or is it zone 4? Red, zone 1. Blue, zone 2. Yellow, zone 3. Or green, zone 4. One of these lesions is at the greatest risk of mechanical failure. And the correct answer is zone 2, as many of you have guessed, but we still have people who have answered differently. So Dr. Harsha, if you can clarify that.
Yeah, so in zone 2 resections, we are removing the complete acetabulum. So part half of the hip joint is gone. So there will be maximum chance of instability. When coming to zone 1, there is only the resection of the iliac bone. There will be discontinuity of the pelvic ring. So the patient might be having some shortening, but there may not be any hip instability. And in zone 3, we are removing the pubis and ischium, which are in the non-weight bearing axis. So there won't be any shortening or hip instability. And the same way, zone 4 also, there might be some amount of shortening, but the maximum amount of its instability, mechanical instability, we will see in acetabular resections.
Yes, yes. Thank you for that. Moving on, and we can have a look at the scoreboard at the end of the 5 questions. Roshan is leading with Prashant second and NK third. Others have a chance to catch up since we have 5 more questions remaining. So moving on to the next question, the 6th question. The following systems of ablation use energy to heal the tissue except radio frequency ablation, high intensity focused ultrasound, microwave ablation, or is it green cryoablation? One of these doesn't use thermal energy to heal the tissue. Is it radio frequency ablation? Is it blue high intensity focused ultrasound? Is it yellow microwave ablation? Or is it green cryoablation? There is a dispersion of the answers, but the correct answer is cryoablation. Dr. Harsha, if you can clarify that.
In cryoablation, we won't be using any heat, and the major source is the gas. We use the liquid nitrogen gas so that the temperatures are reduced in the tissue so that we will get a ice ball to destroy the tissue.
Yes, yes, yes. Thank you for that. So it doesn't require thermal energy. It uses cold to cause an ablation. So moving on to the next question, skip the scoreboard again. And we will have real-time tissue damage can be monitored in which of the following modality? Is it red, cryotherapy? Is it blue, radio frequency ablation? Is it yellow, microwave ablation? Or is it green, none of the above? Which of these modalities can you have real-time tissue damage monitoring? Is it cryotherapy, RFA, microwave ablation, or none of the above? And majority have guessed it correctly, cryotherapy. Dr. Harsha,
yeah.
If you can
so in cryotherapy, as Dr. Kunal Gala has already delivered in his lecture, that there is a ball formation, ice ball formation, so which can be seen or appreciated in the CT. So whenever the ice ball is approaching onto the critical structures or into the soft tissue, we can reduce the intensity or we can stop or halt that, which we can't have those type of monitoring in radio frequency or microwave ablation.
Yes, yes. So that is the correct answer. Moving on. There is a change which you could see after this question. USP6 gene rearrangement is seen in which of the following? Is it red, simple bone cyst? Is it blue, aneurysmal bone cyst? Is it yellow, giant cell tumor of the bone? Or is it green, fibrous dysplasia? USP6 gene arrangement. Simple bone cyst, aneurysmal bone cyst, giant cell tumor, or fibrous dysplasia? Final 6 seconds to answer this question. 3, 2, 1. And the correct answer is aneurysmal bone cyst, but many have answered it as fibrous dysplasia. Dr. Harsha, if you can please
tell us. This is the invention of our molecular analysis, USP6 gene rearrangement, is mainly seen in the primary aneurysmal bone cyst. This is mainly used to differentiate primary aneurysmal bone cyst from secondary aneurysmal bone cyst, which we usually see in fibrous dysplasia or a giant cell tumor or some sarcomas like telangiectatic osteosarcoma or something. So this is to differentiate that. Yeah.
Yes, thank you. So now we have finished 8 questions. So let us have a look at the scoreboard at the end of 8 questions. There are slight changes, and Roshan is still leading with Narendra in second and Aarti in third. Manish and Naveen have a chance to catch up since we are having still 2 more questions to go. Thank you. Now let us go on to the 9th question of this quiz. Which of the following is not a contraindication for Cannibal technique? You will have 4 images: red, blue, yellow, green. So which of these is not a contraindication for Cannibal technique? Is it the red? Is it the blue? Is it yellow? Or is it green? It's an image-based question. You could see the images, and many of you have answered correctly, but there's still some people who answered different. Dr. Harsha, if you can please clarify.
It was clearly explained by Navneet in his presentation that the lesion should be like away from physis. Like if you consider all the 3 other options, like entire physis is involved or crossing the physis and with a pathological fracture or contraindications, because the physis is not free in those others. And then the pathological fracture, if you distract the bone, the sarcoma will be distracted. So answer A is correct. Yeah.
Yes, a couple of them are relative contraindications, but still the red one is the one where it is a clear indication to do the Cannibal technique. So thank you. We move on to the next question. We'll skip the scoreboard so that there is some excitement for the last question. And coming up, registration error happens in navigation surgery when there is a mismatch between the name registered in hospital data and images. The software is not able to read the images. Mismatch between preoperative fused images and patient anatomy, or is it green? Sensor is not able to pick up the fiducial points. Registration error in navigation surgery, is it red? Mismatch between name registration. Blue, software is not able to read the images. Yellow, mismatch between preoperative fused images and patient anatomy. Which is what the correct answer is? Dr. Harsha, back to you.
Yeah, as most of them have answered correctly, it is very clear from Dr. Rudra's presentation that there is a mismatch between preoperative fused images and patient anatomy. It will cause registration error, and we should be very meticulous while matching on the body intraoperatively so that the registration error is less than 1 mm, so that we get that accurately.
Yes. Thanks a lot for that. And with that, we come to the end of this quiz. And let's have a look at the final scoreboard at the end of the 10 questions. Thanks a lot to the 10 delegates who participated. At number 3, we have Naveen, who has answered 6 out of 10. At number 2, we have Narendra, out of 7 out of 10. And number 1, we have Roshan, who was consistently at the top. Congratulations, Roshan. If you're still online, can you switch on your video and give us a feedback, please? Roshan Guacha, I can see you are there. If you can just switch on your video and give us your feedback, please.
Yes, sir.
Hi.
Hello.
Hi. Thank you for participating. How did you find the session and how did you find the quiz?
First of all, I would like to thanks for this wonderful day.
Yes, thank you.
And I'm Dr. Roshan, and I'm doing residency in Nepal.
Oh, that's wonderful. Yeah.
And today's topics is so much useful for me. And this today's classes will help me in exam as well as in daily life.
That's great. You're doing residency in orthopedics?
Yes, sir.
Oh, that's good. Thank you for participating. And in fact, the next session is the last session of our series this year, which will be on case-based discussions. So hope to see you there, and you can spread the messages, because that is just pure short and long cases will be discussed with respect to how to conduct that in exams as well.
Yes,
and that is the last session of our series. There won't be any quiz in that session, but this will be very helpful from exam point of view.
Okay, sir.
Thanks a lot to everyone who stayed back till the end. And thank you, Harsha. Thank you, Rudra. Thank you, Somnath ji.
Thank you.
We'll see you on 8th of July for the final session.
Thank you.
Thank you. Thanks a lot.
Thank you.
Okay, Emanji, Somnathji, thank you. We'll get back next week with the final flyer for this final week, and then we can circulate that.
Okay, sir.
Okay. Roshan will get in touch with you for the details for the prize money.
Okay, sir. Okay, thank you.
Yeah. Okay. Thank you. Thanks a lot, everyone.